Yeah. So in association with Ready Stocks, we have come up with sessions on GI physiology every month. And this month, we'll be discussing on anorectal manometry. And the speaker is none other than our Dr. Shrihari Anikhindi, sir, who practices in Sri Gangaram Hospital. Thank you, sir, for accepting our invitation. It's a great privilege for our Evolving Gastroenterologists Association to have you in this podium. And a lot of students and young practitioners in medical gastroenterology will be really benefited from the evolving sciences in GI physiology. And we feel that anorectal manometry again is something which is going to have an increasing footsteps all over the country. So this session will be from basics, and we thought that you would be the best person to deliver on this particular topic. So the entire session will be closely to around 50 minutes, followed by a Q&A session, sir. Slowly, more students and young gastros and practitioners might be joining over time. So we can start off, sir. Thank you. It's our pleasure to have you here.
Yeah, thank you so much, Dr. Prashant. I am really grateful to you for this opportunity, and I must congratulate you for this innovative idea of bringing young gastros together on a platform to discuss about these techniques or these tests, which usually is not talked of very often. We are all, as gastroenterologists, we do have a good exposure to endoscopy, but these GI physiology tests are very less often discussed, and especially at centers where they are not doing these tests very often. I think a little bit of hand holding is required, and now in this digital era, I think this can very well be done even on a national scale with programs like this. So I really congratulate you, and also I thank ReadyStock for initiating this kind of program. So I shall share my screen now. Yeah, so my screen is visible, Dr. Prashant?
Yes, sir. It's visible.
Okay, so in the next 50 minutes or so, I shall be discussing about anorectal manometry. I believe we have already had one session on esophageal manometry. And I bring greetings from Sir Gangaram Hospital. I'm working as a consultant gastroenterologist there, and my primary interests lie in therapeutic endoscopy and GI motility. We do have a very high volume center where we perform a lot of motility and manometry cases. Right. So let's first discuss about how does manometry come into play in routine GI practice, right? So to understand that, we need to first know about the physiology of stool evacuation. So basically, once the stool starts forming in the large bowel, there is an ab-oral propulsion of the stools, and this is aided by the movements of the colonic muscles, and the stool just goes on ab-orally. And once it goes ab-orally, it does not just drop down like that. It comes into the rectum, and first there is a filling of the rectum which occurs. And the rectum, as we all know, is a capacious reservoir. So the rectum has a capacity to accommodate a certain amount of stools, and once there is a certain amount of stools which come into the rectum, there is generation of these rectal sensations through the mechanoreceptors and the sensory receptors which are present in the rectum. And once these sensations are elicited, there is an urge that is generated to defecate, right? Once this urge occurs, then there is an evacuation. So this evacuation also is a very coordinated process. Okay, it's a coordinated process where there is a coordinated increase in the rectal pressure, and at the same time there is a decrease in the anal sphincter pressure, which is done when we have a socially suitable environment, and this is when the stool evacuation occurs. So this last step of the evacuation of stools is what we test basically when we are doing a anorectal manometry, especially for patients with constipation or fecal incontinence. Right. So before we go into manometry in detail, I would like to use this forum to tell you about the basics of what the water perfusion manometry, how it really works, right? So you must all be, most of the centers, especially in India, I think 95% of the centers still are using a water perfusion system. And what is there in a water perfusion system is that you have a chamber of water somewhere around your manometry machine, which is holding up this water. And this water is being propelled under a certain pressure through these tubes, right? Through this tube. And this water pressure can be maintained by a regulator, which you must all be having. And then this water flows through this intricate set of capillaries that are attached. And all these are then eventually connected to one single catheter, which goes in the area of interest, right? So in this water perfusion catheter, you will see that there is water dripping across these various channels that are present in the manometry catheter. So whatever resistance comes to the flow of this water at these various channels, that is converted in the form of pressure graphs, and that is what you see on the screen. So you will be seeing different colors which tell us about the pressures being generated, and that pressure is sensed by the resistance to the flow of this water at the various levels in the catheter, right? So in anorectal manometry, the catheter is inserted through the rectum, and this is how the patient's position usually is. He's in the left lateral position, comfortably lying down. And I would recommend that for all centers who are doing anorectal manometry, there should be one screen for the patient to see and one screen for the operator, because this screen is useful because when you are doing an anorectal manometry, you would also be interested in doing something called biofeedback. And biofeedback is where the patient should also be actively engaged and actively participating. So he should know and he should see what is happening on the screen, right? So this is an ideal setup for an anorectal manometry. Okay. The best part about anorectal manometry is that it hardly requires any elaborate preparation. There is no fasting. There's no fasting that is required. Sedation is absolutely not required. Colonic preparation is also not required. All you need to do is just give an enema, like a proctoclysis enema, maybe half an hour, 1 hour before the procedure. The patient's position is left lateral. And there is one simple thing that I wish to tell you all, that we should, for lubrication, it is recommended that you should not use a lignocaine jelly, which is often used by many, because this lignocaine is an anesthetic, and one of the tests that we do during anorectal manometry is to check for rectal sensations, which might be hampered because of this. You can use other lubricants which are available, like a KY jelly, right? So before we do an anorectal manometry, it is important also to do a simple digital rectal examination to check if there are any palpable abnormalities, like any presence of stenosis, any painful lesions, etc., which might, painful lesions like an anal fissure, which might impair placing the catheter, and they might also give you false results because the patient is in pain. It has also been published that doing a digital rectal examination can also give you a fair assessment of dyssynergia. Of course, that requires a little bit of experience, and the sensitivity in such cases by doing a digital rectal examination is to the tune of around 70 to 75%, as published in the studies. Okay, so when we do an anorectal, the patient is in this position, and when we do an anorectal manometry, the catheter is placed around 10 centimeters into the rectum. That is, it is up to the first or the second rectal folds. And usually in an anorectal manometry, you have a balloon tip. The tip has a balloon. So this balloon is used for inflation. This inflation is useful for multiple maneuvers like finding about the sensation or the balloon evacuation test. So when this catheter is inside, this is what is usually seen at baseline, right? So as we discussed that it shows us the pressure. So we all know that the anal sphincters are always contracted at rest. So the anal sphincter is predominantly the internal anal sphincter and the external anal sphincter. The internal anal sphincter is the smooth muscle. The external anal sphincter is the skeletal muscle. the internal anal sphincter is involuntary and the external is voluntary. So at rest, the internal anal sphincter is always in a state of tonic contraction. And that gives us this constant high pressure zone that we see here. The high pressure is pinks and blacks that we can see on the scale. So this is the high pressure zone that we see. The low pressure zone up is the rectum, and the low pressure zone out at the bottom is the exterior, right? So on the left hand side, we see these positioning of these channels. So the anorectal manometry catheter is designed in such a way that the catheter, the sensors are closely placed in the area of the anal sphincter. So here you see the sensors being close to each other as compared to over here, right? So this is the baseline graph that you usually see. So once this catheter has been placed, there is a recommended protocol that has to be followed. This was with the recently published London classification, which has standardized the way to do the anorectal manometry. So after the catheter has been placed, there is a stabilization time of around 3 minutes so that the patient gets comfortable. You see that the graphs that are coming are stable. Then you give the patient a short rest, and then you ask the patient to start squeezing. So there are 3 squeezes that are to be done with a 30-second interval in between. Then there is a long squeeze which has to be done, which you ask the patient to squeeze as long as possible for at least 30 seconds. Then you ask the patient to do a cuff maneuver. Two cuff maneuvers are done. Then a push sequence is initiated. You do a push sequence for 3 times according to the London classification. Then you check for the recto-anal inhibitory reflex. Then you check for the rectal sensory testing, and last you see the balloon expulsion test. Okay, so this is the protocol that is to be followed, and I'll be discussing these all maneuvers in detail. Okay, so let's talk about short squeeze. So when you ask the patient to short squeeze, this is how the graph will look, right? So you have this high resolution, the high pressure zone over here. This was normally what was seen at rest. You have asked the patient to squeeze. So when the patient squeezes, the external anal sphincter comes into play, and now you see a high pressure zone over here. So this is the squeeze pressure that can be seen, and this squeeze pressure can be is evaluated within this box. So this is above the sphincter, this is below the sphincter, this is beginning of squeeze, and this is end of squeeze. So whatever pressure is over here, the median or mean can be assessed. Okay. So after the squeeze, we talked about long squeeze, or this is also called as the endurance squeeze. So you are asking the patient to squeeze as long as possible, and this is how the graph will usually look like. There is a prolonged state of contraction that is there, and you will assess how long the patient is able to do that. Okay. With a cuff, you're asking the patient to cuff, and what would normally happen with a cuff maneuver is that when the patient is cuffing, now because you're cuffing, the intra-abdominal pressure rises. You see this rise, this is the rectum, right? So the rectal cavity is in continuous contact with the abdominal cavity, and when the patient is cuffing, there is a rise in the intra-abdominal or the intrarectal pressure, and that would be seen as an uptick in the pressures in this area. At the same time, you would see that the sphincters also squeeze. So this is because of an involuntary contraction of the external anal sphincter when you are cuffing. So this is a protective reflex. This is meant to prevent the stools from jutting out when the patient is exerting any kind of pressure. So with a normal cuff reflex, you would expect a rise in the intrarectal pressure, and at the same time a concomitant rise in the intrasphincteric pressure, right? So after cuff, you see for a push maneuver. So what do you normally see in a push is when the patient is doing a push, this was the baseline rectal pressure. He's now pushing, he's trying to evacuate. So the pressures in the rectum starts increasing, and gradually you will see that the anal sphincter will start relaxing. So here you see that the sphincter was darker, and gradually you will see that the sphincters start relaxing. So this is what you normally see in a push maneuver, right? Sometimes with a push maneuver, you would see that the intra-abdominal pressures rise to a certain level, intrarectal pressures rising, but the sphincters also start contracting. There is a paradoxical contraction. You see here at the baseline, this is the sphincter pressure, but over here, the sphincter pressure has actually increased. And this is an example of dyssynergia. So what is happening in dyssynergia? Dyssynergia is no synergy, yeah, or abnormal synergy. So there is a rise in the rectal pressure. Normally the sphincter pressure should have gone down, but here the sphincter pressures are paradoxically increasing. So with a push maneuver, you can see a graph like this, and this is a dyssynergic defecatory pattern, right? Then comes an important reflex called recto-anal inhibitory reflex. So what is happening in RAIR is that we discussed about the balloon that is present inside the rectum. So you inflate the balloon, and once you have inflated the balloon, here you see that the rectal balloon has been inflated, and once the rectal balloon is inflated, you see that the sphincter pressures go down and down and down. Okay, so this RAIR actually helps us in evacuation of the stools. This is a normal reflex which is present in normal individuals. So what happens in RAIR is when the rectum gets inflated, the internal anal sphincter relaxes. Okay, so what actually happens during normal physiology is when the rectum is inflated, or when the rectum gets filled because of the stools, there is a phenomenon called anal sampling. So what happens in anal sampling is when the rectal filling occurs, the anus actually has the capacity to sample the contents of the rectum and find out whether that is solid fecal matter or it is just gas. If it is just gas, it will allow you to evacuate that gas if it is socially permissible. But if it is solid stools, there is a contraction. There is no relaxation that occurs. So this is RAIR, recto-anal inhibitory reflex. RAIR should be normally present in normal healthy individuals. Okay. Then comes the how do we use this? And so then comes the rectal sensory testing. In rectal sensory testing, what we do is we use the balloon and we go on gradually increasing the inflation of the balloon, either by putting in water or air. And you see for three sensations, you check what is the first sensation when the patient is able to recognize that there is something in the rectum. Then you see the second sensation, that is the urge to defecate. And the last sensation is when the patient can hold it no longer, and that is called as the maximal tolerable volume. Okay. And the last maneuver is the balloon expulsion test. So in balloon expulsion test, you first inflate the balloon to around 50 cc of water or air, and you ask the patient to expel that balloon by giving him a time of around 1 minute. So you don't need a manometry apparatus for that. That can also be done with a simple catheter with a balloon attached to its tip. And the intent of doing this test is to see whether within 1 minute the patient is actually able to do the process of evacuation and push the balloon out. So the balloon serves like a artificial stool. Okay. So these are the maneuvers that are done in a normal anorectal manometry. Okay, so let's go to one by one. So first we saw about the resting anal pressures, right? So what inference can be made from how to use the anal pressures for making some inference with an anorectal manometry? So at baseline, we all know that the internal anal sphincter contributes to 60% of the anal tone. The external sphincter contributes to 30%, and the hemorrhoidal plexus contributes around 10%. So we have published normative values with an Indian population, which has given us the normative values for the sphincter. So in females, the resting anal pressures are usually slightly lesser than males, and these are the normative values given for the Indian population. Also, it is seen that with increasing age, the resting anal pressure goes on decreasing. Okay, so you might have situations where there is a high resting anal pressure, like if there is an anal fissure, or there might be proctitis, which can lead to high anal resting pressures. Low resting anal pressure, if you can see, that might be secondary to Usually in females, it is because of obstetric trauma, also called as OAC. It might be secondary to road traffic accidents. It might be seen secondary to post-anorectal surgeries. It can be seen in very elderly patients with comorbidities, right? So now the London classification has reclassified a high resting anal pressure and called it anal hypertension. So you should now know all these names. So now in future, it might not be known as a high resting anal pressure. It is called as anal hypertension. And a low resting anal pressure is called as a anal hypotension. Okay, this is the standard terminology that has been brought in. Okay, so then we saw about the anal squeeze. So anal squeeze, again, we have these normative values which are published. Squeeze pressures are lesser in women as compared to men, and they are lesser in older as compared to younger people. Okay, so there is no connotation for a high squeeze pressure. That does not have any clinical relevance. But yes, if you have a low squeeze pressure, this might be secondary to conditions like obstetric trauma, road traffic accidents, post-anorectal surgery, elderly patients with comorbidities, and some patients with a history of sexual abuse, right? So uh, this low squeeze pressures is now called anal hypocontractility. So with the London classification, this has been relabeled to standardize this as anal hypocontractility, right? Then we saw about the cuff reflex test. So what is happening in a cuff reflex test is that an increase in the intra-abdominal pressure causes a sphincter reflex contraction of the anal sphincter, right? So how does the cuff reflex actually help us clinically, right? So it helps us actually to check the integrity of the local neural reflex arc. Okay, so if you have a normal cuff reflex and a normal squeeze pressure, this is a normal finding. Okay, in patients with fecal incontinence, the cuff reflex is very useful because if you have an absent cuff reflex, okay, the patient is cuffing, but there is no paradoxic, there is no contraction of the sphincter. This is because the defect is there somewhere in the sacral reflex arc. Huh? This might be seen in sacral nerve injury or cauda equina syndrome. Okay, but there can be a situation where there is a cuff reflex is normal. Okay, so cuff reflex is normal means the patient is cuffing and there is a contraction of the external sphincter, but the squeeze pressure is low. Okay, this is seen in a situation where there is a defect in the central motor pathway at a upper motor neuron level, that is in a pathway which is above the sacral segment. So this is how the cuff reflex is useful for neurological evaluation in routine clinical practice. Okay, so we also discussed about another reflex called RAIR, which is again a very, very important reflex. So what does RAIR tell us? RAIR actually tells us about a local active reflex. So local active reflexes, these are these intrinsic myenteric neurons present in the rectum and the anal sphincter, which help in relaxation of the internal anal sphincter when there is inflation of the rectum. So when RAIR is present, it is a normal finding. So if RAIR is present, Hirschsprung is certainly ruled out. Remember this. So it has a negative predictive value. So a present RAIR means Hirschsprung is ruled out. Okay. But if you have an absent RAIR, that does not mean it is Hirschsprung disease, because an absence of RAIR might be seen in other conditions also. It can be seen in Hirschsprung disease very commonly, but it can be seen in cases with myotomy, in cases with low anterior resection, in Chagas disease. In some patients with anal fissure, you have a rebound contraction after RAIR. In patients with proctalgia, you can have rebound contraction after RAIR. So an absence of RAIR does not necessarily mean that this patient has Hirschsprung disease. It just means that there is something wrong in the local reflex. But yes, if the RAIR is present, Hirschsprung is ruled out. So it has a negative predictive value. Okay. So then comes about the rectal sensory testing. So as I discussed, the rectal sensory testing is checked when you start inflating the rectal balloon with air or water. And the inflation can be done in a continuous manner or in a ramp fashion. So ramp fashion means you inflate 10 ml, then again completely deflate, then you go on to inflate 20 ml, then again you deflate it completely, then 30 ml and again deflate completely. So that is a ramp method. Continuous is inflate 10 ml, ask the patient from 10 to go on to 20, ask the patient from 20 go on to 30, ask the patient. So that is a continuous method. So the recommended maximum distension is around 400 ml and 3 sensations are tested. What is the time when the patient feels the first constant sensation, and when does the patient feel the desire to defecate, and when does the patient feel about the maximal tolerated volume? So again, we have these normative values which have been published in 2022 in Indian patients, right? So when do you see an increased sensation or rectal hypersensitivity? That means the patient tells that the sensations have come earlier, or they feel these sensations at lower volumes of distension. So this can be seen in patients with proctitis. It is seen very importantly in patients with IBS, because IBS, as we all know, is associated with visceral hypersensitivity. And it is shown that visceral hypersensitivity actually leads also to rectal hypersensitivity, because it is actually a cavity in contiguum with the abdominal viscera. So in patients with IBS, you can see rectal hypersensitivity. It is seen in patients with urge fecal incontinence. Rectal hyposensitivity, on the other hand, is usually seen in patients with chronic constipation, because they do tend to have a lot of rectal retention over a period of time, and eventually leads to a ballooning of the rectum, causing a megarectum, and that eventually leads to decrease in the mechanoreceptors and the sensory receptors in the rectum, and eventually leads to rectal hyposensitivity. Okay, now again, the London classification has standardized when do you label these patients as rectal hypersensitivity. So for rectal hypersensitivity, you need to have more than or equal to one sensory threshold above the upper limit of normal. We talked of the 3 sensations. The first sensation, the desire to defecate, and maximal tolerable volume. Rectal hyposensitivity you label when you have 2 or more, that is 2 or all 3 of these sensations below the lower limit of normal, right? So for hyposensitivity, you need to have 2 or more. For rectal hypersensitivity, 1 or more is sufficient. Okay. Simulated defecation, we already discussed. You ask the patient to bear down, and you ask the patient to bear down when you inflated the balloon with 50 ml of water or air. We usually use water because it could be more physiological in feeling. You in the West, you also have a fecome, which is a material similar to stools, because you need to generate that actual environment. And this is a very important step, because it is a crucial step to evaluate for dyssynergia. And it has been shown that the high resolution manometry has around 80 to 85% sensitivity and specificity to evaluate for anorectal dyssynergy. So the normal defecatory pattern would be something like this. You have the normal sphincter here. This is what the rectum is seen at rest. And when you ask, and when the patient is evacuating, the intrarectal pressure rises and the anal sphincter relaxes, right? So this is the normal defecatory pattern. In dyssynergia, you would see a paradoxical contraction of the sphincters usually. You have 4 types of dyssynergia that have been mentioned most commonly. In certain papers, 4 types are also 4 more types have also been mentioned, but this is usually the most commonly used classification. So in type 1 dyssynergia, you have an adequate increase in the rectal pressure, where the rectal pressures are at least more than equal to 40 millimeters of mercury, and at the same time you have simultaneous increase in the anal sphincter pressures, right? In type 2 dyssynergia, you have an inadequate increase in the rectal pressure. So there is some increase in the rectal pressure, but it is not significant. It is less than 40 millimeters of mercury. But you also have a paradoxical increase in the sphincter pressure. So here what is happening? There is some increase in the rectal pressure, not clinically significant. There is a paradoxical contraction of the anal sphincter. In type 3 dyssynergia, you have an increase in the rectal pressure. So the rectal pressures are generating well, that is more than 40 millimeters of mercury. But here there is no paradoxical contraction, but there is a failure of relaxation. So relaxation normally should be more than 20% of the baseline sphincter pressure. So there is a failure of relaxation. There's no paradoxical contraction, there's a failure of relaxation. And in type 4 dyssynergia, you have an inadequate increase in the rectal pressure. So the rectal pressure is not rising to more than 40 millimeters of mercury. And at the same time, there is a failure in the relaxation of the anal pressure. There's no paradoxical contraction, but there is a failure of relaxation. So based on the combinations of the rectal abnormality and the sphincter abnormality, these are the 4 types of dyssynergia that have been mentioned. Okay. So then comes the balloon expulsion test. Here you're asking the patient to expel a 50 cc inflated balloon, that is air or water. And you usually give the patient somewhere between 1 and 3 minutes. 1 minute is what is the most commonly used norm in most of the centers. And you ask the patient to evacuate that, right? So this does not, as I discussed, does not need a manometry apparatus. It can be a simple catheter, any catheter where a balloon can be used. Even a Foley's is good enough, but here 50 cc is required. That has to be inflated, and you give the patient a defined time. And the best way to do that is you give the patient privacy, allow him to sit on a potty, on a squatty potty, and give the patient time to evacuate in 1 minute and see whether the patient has been able to evacuate the balloon or not. Okay, when you are doing it on a manometry system as a last step, so because the patient is in the left lateral position, usually it is normal to give a slight traction to the catheter so that you can aid in the evacuation. Some of the papers have also told us about using a pulley with a defined weight so that it can be standardized, right? So recently we had something called as the London classification. So why this London classification was important? So basically what is happening is that many centers are doing manometry, but when it comes to publications, everybody is using their different nomenclatures and different cutoffs. Okay, so there is a very interesting story which comes from the biblical era, and this is the Tower of Babylon story. So what happened is, it is said that when humans they started advancing with technology, many people came together and they started building a huge monument which almost started reaching the sky. And when God saw this, he became very fearful, and he thought that his dominance would be lost if the humans progress so well. So what he did is he created different rooms in this monument and put all these people in different rooms. And each person was given a different language. Okay. So because of different languages, the people just could not communicate with each other, and hence they could not collaborate and they could not progress. And this is the Tower of Babylon situation. So to avoid this Tower of Babylon situation, we have the Chicago classification, which is doing very well for the esophageal manometry. It has come to its 4th reiteration. For anorectal manometry, this process has just started. Okay, so this is now called as the London classification. So the London classification is trying to standardize the different things that we see in a normal anorectal manometry, right? So coming to the defecatory patterns. So if the balloon expulsion is absent, or you can also see it on a defecography, if the expulsion is absent, the patient is having a normal anal contraction, the rectal pressure generation is normal. So this is called as abnormal expulsion with dyssynergia. So abnormal expulsion because the balloon is not expelled and there is a paradoxical contraction when the patient is trying to expel. The rectal pressure generation is normal. So this is called as abnormal pressure expulsion with dyssynergia, right? If you have a abnormal balloon expulsion, the patient has not been able to expel the balloon, right? The anal contraction is not there. The sphincter is relaxing. Okay, but the problem is there because the rectal pressure generation is not there. Okay, one of the dyssynergic patterns was showing that. So here what is there? The patient is not able to expel the balloon. Expulsion is not happening because the rectal pressure generation is poor. The anal contraction is relaxation is normal, right? So this is called as abnormal expulsion with poor propulsion. Okay, this is not termed as dyssynergia in the London classification. Okay, if you have an abnormal balloon expulsion, okay, that the balloon expulsion was not done by the patient. When the patient is trying to evacuate, there is an anal contraction. When the patient is trying to evacuate, the rectal pressure generation is poor. So in this case, it is called as abnormal expulsion because balloon could not be passed, poor propulsion because the rectal pressure is not generated, and dyssynergia. So they have labeled dyssynergia only when there is a paradoxical contraction of the anal sphincter. Okay, so the London classification comes up with this term of dyssynergia only when there is a paradoxical anal contraction. Okay, and mind you, it should always be associated with a poor balloon expulsion. So balloon expulsion should be absent. That is mandatory. Okay, if the balloon expulsion is present, okay, in this case the balloon expulsion is present, but you see a anal contraction. So there is a paradoxical anal contraction. So here it is again not called dyssynergia. See, in London classification, this is not called dyssynergia. Even if you see it in the graph, it is not called dyssynergia. So you should have both. You should have the first prerequisite is the patient should not be having a balloon expulsion normal. The balloon expulsion should be absent, only then we talk of dyssynergy. So you have a situation when the balloon expulsion has occurred, there is a paradoxical anal contraction and the rectal generation is normal, or the rectal generation is poor with an anal relaxation. So this looks like a dyssynergic pattern over here. Okay, if you see in this case, this both look like a dyssynergic pattern. But because the balloon expulsion is present, this is not labeled as dyssynergia. This is called as normal expulsion with abnormal manometry pattern of recto-anal coordination. Okay, so this we often see in clinical practice. You see a balloon expulsion test not being done properly. The balloon does not just come out, but when you see the graph, it might be something different. Or you see that the balloon has come out, but you see a paradoxical contraction of the sphincters, because in normal people also sometimes you see these dyssynergic patterns. And this is a very, very relevant, a very good thing that they have come up with. And I think all people who are doing manometry should start reporting in the London classification nomenclature. I am pretty certain that the previous studies which have been published on dyssynergy are probably missing out on this point, right? And if you have a absence of balloon expulsion, the anal contraction is relaxation. There is a relaxation of the sphincter. The rectal pressure generation is normal, but here the balloon has not been expelled. Okay, so here the parameters are normal, but the balloon is not being expelled. So this is called as abnormal expulsion with normal manometric pattern of recto-anal coordination, right? So basically the crux is you need to have problem both with the balloon expulsion as well as a dyssynergic pattern here. Only then it is called as a dyssynergy, right? So we talked about the various maneuvers in manometry and how do these help us in clinical practice. You see for the RAIR very carefully when you're suspecting that this patient has Hirschsprung disease. Okay, very commonly this situation might arise in a young child who's being referred to you with chronic constipation, and here you would see for RAIR. So here I would like to make one important note is that when you do this manometry in children, especially the very younger children, the child should not be crying when the manometry is being done, because if the child is crying, he would paradoxically automatically be contracting his external sphincter, and because of that we might not be able to see the relaxation of the internal sphincter when we are doing the RAIR. Okay, for patients with chronic constipation, if suspecting dyssynergia, you would see for the dyssynergic patterns as we discussed. Rectal hypo or hypersensitivity is useful in diagnosing patients with constipation, with patients especially with IBS and some anorectal pain syndromes that I'll discuss. And sphincter pressures are especially useful if the patient is presenting to you with incontinence, right? So different clinical scenarios, and you'll be focusing on different parameters. Obviously, you'll be doing all, but see these more carefully, depending on what is the indication for manometry, right? So the anorectal manometry is useful in patients with refractory constipation. It is used not only for diagnosis, like maybe patients with Hirschsprung disease or dyssynergic defecation, but it might also be useful in treatment like biofeedback. So biofeedback we are not covering in this because that itself is a different topic, right? But it can be used for treatment purpose for biofeedback. It can be useful in patients with fecal incontinence for diagnosis as well as therapy. So fecal incontinence patients also do very well in biofeedback. It can be useful in patients who are presenting with anorectal pain syndromes. It can be used as a diagnostic aid and can be used for biofeedback for patients with levator ani syndrome. It is useful for pre-operative patients, especially for patients who have come for reversal of a colostomy, because with time the sphincters tend to become atrophic if they're not used for a certain period of time. For post-fissure surgeries, they can be used, and in female patients especially, it is used for assessing the anorectal integrity after an obstetric injury of the sphincter apparatus. So this future mode of delivery and whether they can go in for a vaginal delivery or they have to go for a LSCS. Okay, so most commonly among these, we usually in common clinical practice, it is used in patients with refractory constipation and patients with fecal incontinence. Okay, so there are a few anorectal pain syndromes. These are usually rare, but you would be having certain patients coming to you with unexplained anorectal pain. There are three clinical conditions of anorectal pain syndrome, that is a proctalgia fugax, levator ani syndrome, and functional anorectal pain. So in proctalgia fugax, the nature of pain is very sharp, whereas it is usually dull in levator ani and functional anorectal pain. Here it's a sharp shooting pain which lasts for certain minutes, for a few minutes or few seconds, whereas the pain stays longer in these two conditions. The pain is intermittent, it comes and goes, is very short lasting, but here the pain tends to be more chronic. On a PR examination, the proctalgia fugax would be normal. In levator ani syndrome, you would elicit a rectal tenderness most often, which is normal in a functional anorectal pain. The manometry is useful in diagnosing patients with levator ani syndrome because here up to 70% of the patients might show dyssynergic patterns, and these patients might improve with biofeedback. So a levator ani syndrome is where you can make good use of your anorectal manometry. So a typical patient with levator ani syndrome would be having a dull anorectal longer period of time. It is usually chronic. You do a PR examination, you often elicit rectal tenderness, and you might see dyssynergia in a lot of these patients, and they tend to improve on biofeedback. So that should be offered to these patients, right? So, ladies and gentlemen, my take-home message from today's meeting is that the anorectal manometry is an excellent test to make a functional assessment of the anorectal apparatus. It is safe, easy to perform with very good patient acceptability because there is hardly any pain, there is hardly any discomfort. There is a proven utility of anorectal manometry, especially in chronic constipation with patients with dyssynergia. It can also be a useful tool to diagnose IBS indirectly. It is useful in patients with fecal incontinence, useful for biofeedback. It may be useful in Hirschsprung disease very often, anorectal pain syndromes, as well as in patients with obstetric injury of the anorectal sphincter. Right? Thank you so much. Thank you for your participation.
Thank you, sir. Wonderful deliberation. Really basics to the London classification and the Tower of Babylon trying to divide and rule and how it's unified by this current system. Really, thank you, sir. A really useful session. With respect to GI physiology, especially anorectal manometry, again has a lot of implications considering the incidence and the prevalence of these functional constipations that are occurring. And then dyssynergia is a common terminology, and again in that subdividing them, and then how London classification actually gives more importance to balloon expulsion rather than the patterns of just manometry. All of it really great, sir. Thank you for the wonderful session. So sir, from your practice, like you would have seen many numbers, so maybe you share over next 5 minutes, like any different cases that you came across and how they manage, like especially with this conditions of anorectal manometry, sir. And then at last, you also mentioned about the proctalgia fugax and the other conditions where biofeedback also can actually help. Like these, we haven't really heard of. So maybe from experience, if you're able to tell us, that would be great.
So the most common indication for anorectal manometry obviously is patients with chronic constipation. I would recommend that any patient who comes to you with chronic constipation, unfortunately the practice is that whenever a patient comes with chronic constipation, we all do a colonoscopy. And what is the yield of colonoscopy in a patient with chronic constipation? Zero. Okay. The only indication for colonoscopy, if you go by the guidelines, is patients having red flag signs when they present with constipation. Right? Red flag signs is anybody who's elderly, who has blood in the stools, who has unexplained weight loss, or there is a recent onset constipation with a change in the caliber of the stools. So these are the red flags where you would go in for a colonoscopy. Otherwise, for these conventional patients who are coming with chronic constipation, colonoscopy has zero value. But we still do that because we're all used to doing that. But I think a manometry is a much more useful test in such cases. Okay, you do a manometry and you would be surprised to see that dyssynergia is pretty common. Pretty common. But here I would also like to tell you that just don't diagnose dyssynergia because you are seeing that graph. Okay, dyssynergia is a combination of tests. It's a combination of an abnormal balloon expulsion. You would see an abnormal graph. You would see that if you do a barium deficogram or MR deficogram, the patient is not able to evacuate. So use at least 2 out of these 3 tests to label as dyssynergia. So 2 out of 3 is, what are the 3? Balloon expulsion, the graph on the manometry, and the barium or MR deficogram. 2 out of these 3 positive, more likely that you actually have a patient with dyssynergia. The problem with physiological tests, let me tell you this again. So these are all physiological tests. Okay, there is a difference between a test done for anatomy and there's a difference between a test done for physiology. When you talk about physiology, there are many things which are coming into play. So if you take the anal evacuation apparatus, it is not just the rectum and the sphincter, right? It is the rectum, it is the abdominal musculature at the top, it is the anal sphincter, it is the levator ani, it is the sensations, it is your hemorrhoidal cushions, it is your social environment. You are asking the patient to do that in front of an audience, right? And that too is not in his toilet, is not at his peace. So you should always interpret these physiological tests with a certain pinch of salt and don't take them actually at face value. You have to do a more global assessment. Now, not like an endoscopy. You do an endoscopy, you see a stricture, and you can jolly well say that this stricture is leading to dysphagia, right? But in manometry, you will have to sometimes, or with a physiological test, you'll have to do certain clinical application, and only then label these patients as dyssynergia, because this question is seen very often, and even we face this very often, that you see dyssynergic patterns in normal people also. Okay, so for labeling a patient as dyssynergia, you need to have 2 or 3 reports positive. So the most common indication is chronic constipation. The second most common indication is fecal incontinence, especially in our gynae department now, because of many sessions that we have done. You can also start this and get in collaboration with your gynae people. There will be a lot of post-obstetric injury patients who come. So the important thing in obstetric injury is that you want to see whether there is a anatomical disruption of the sphincter because of a episiotomy, or there is some neural weakness because the obturator nerve tends to get affected. So that leads to a neural injury, and an anatomical injury is where the sphincter is actually cut. Okay. The anorectal manometry tells us there is something wrong. There is something wrong. The patient is not able to hold. Okay. But you will not be able to differentiate whether this is because of the anatomy or whether this is because of the neurological cause. This is where your sphincter assessment by an MRI or a rectal endo ultrasound helps you to see whether there is actually an anatomical defect or not. Also, when there is a reversal of stoma. So now the surgical colleagues send us a lot of patients before they want to close the stoma. They'll just make sure that the sphincter is competent and patent. So if you have anal hypotension, you would first give these patients some Kegel exercises to increase their sphincter pressures, and only then ask the surgeon to go ahead with the stoma closure. Okay, the anorectal pain syndromes are relatively rare. I remember only one patient offhand where we diagnosed this, but it looks very interesting. And I think because these patients are rare and scattered, if it comes in your routine practice, you can very well use this. You might use this to differentiate among these three anorectal pain syndromes.
Great, sir. Thank you. So we'll straight away take up the question, sir, in the chat box. Can open that. I'll just. Yes, sir. So. Yeah. So the first question that was asked is it better to do at least sigmoidoscopy before doing a anorectal manometry?
Not at all. Absolutely not required. So not required means for an anorectal manometry, you don't need to do a sigmoidoscopy. Obviously, as we discussed, if you think there is a mechanical reason for constipation, you suspect there could be some mass or a stricture, yes. But if you ask me, do you need to do a sigmoidoscopy before an anorectal manometry? Not at all required.
Great. So if the balloon comes out while pushing, then how do we proceed further? In case of SRUS, can we do balloon expulsion study?
So if the balloon is coming out, so when you are asking the patient to evacuate the balloon, what are you looking for? You're looking for dyssynergia, right? So if the balloon is coming out, there's no dyssynergia.
The balloon
Right?
coming out is
The
the
dyssynergia is lost, gone. So I mean, even if you're not able to elicit the pattern, it automatically means the patient has expelled the balloon, and now there's no question of dyssynergia. So this is an important thing which the London classification has brought up. If the patient is able to bring out the balloon, dyssynergia is not there. Not there.
Okay. Sir,
And for SRUS, yes, you can jolly well use this balloon expulsion test, because I think SRUS patients might not be always having a significant pain. Very rare to have some most of them would be having. In fact, for patients with SRUS, dyssynergia is very common. One of the pathophysiologies for SRUS is thought to be rectal mucosal ischemia, which occurs because of a constant dyssynergic defecation. Okay, so that is the reason for development of SRUs, because there is a paradoxical contraction. The intrarectal pressure keeps rising. There is some mucosal ischemia, and that leads to SRUs, an unrelenting ulcer. And if you see an SRUS, treating an SRUS is also very difficult. So biofeedback and correcting the dyssynergic defecation is one of the proven treatments for SRUS. So in SRUS, you must do an anorectal manometry.
So when do we actually do a defecography test? Like sometimes we can do it, sometimes is it just for prolapse, or like what are we really looking for when we ask for a defecography
Yeah,
test? When should we put it in the protocol?
so there are 2-3 situations where so if you're talking about surgical correction of constipation, so when does surgery help you in constipation? There are few indications when you have a large rectocele, not smaller ones. Okay, you have a rectal intersusception or a rectal mucosal prolapse or a rectal prolapse, right? So that can be picked up on a defecogram. So usually with chronic constipation patients, if it is possible, if the patient can afford, we usually do all these tests in all those patients, which includes this normal anorectal manometry, the balloon expulsion test, a defecography also.
Great. Okay. Next question. In London classification, 4 types of dyssynergic defecation, it's labeled differently. How do we report, sir? Should we use the new one?
No, so I just discussed that on the slide.
Yeah.
I think that slide tells you very clearly how that is done.
Absolutely.
So it will take time because anything that is new will take some time. It is a bit complicated. It is a bit complicated, but I think you can all take your printouts and that slide, you can take that printout and just paste it there. And that should help you in labeling these patients differently. So now what we are labeling is very gross, but if you actually see what they have tried to do, they have tried to do it in a more scientific way, which I think will help in a long way in maybe understanding these things better. You see, Chicago also started at a very trivial and a primitive level. Now it has gone to such levels that you can actually see those disorders, esophageal disorders of clinical relevance, and sieve out those that are not of clinical relevance. Like you have an ineffective esophageal motility, might not be clinically relevant. It's just labeled as a minor disorder of motility. So that has come with experience. So London will also help us do that in the future.
Till what length we insert the manometry catheter, sir?
So around 10 centimeters. So usually these manometry catheters would be having a marking at the bottom, which will help you how much it is to be inserted. So basically, it is around 10 centimeters where you would go up to the second rectal fold. It is not a very basically when you insert, you would want to see an area of the rectum, a low pressure zone. You would want to see a high pressure zone in your high resolution area. That is the anal sphincter, and that is how much you need to insert it.
Okay. Sir, are normatives of bed timing equal in both left lateral and squatting position?
The problem with squatting position is I don't think it is practically possible to do a manometry in a squatting position, because in a squatting position, the catheter might just not stay like that. So that is the biggest fallacy of an anorectal manometry, is that I think almost all the studies have been done in the left lateral position. It is, I don't think it's virtually possible to place a catheter in a squatting position and it would stay just like that, because I'm not sure, but I don't think that a squatting position manometry normative values we have, or they have been done.
Okay. Dr. Sriram has asked, balloon expulsion happens in less than 50 seconds, and during push, not enough sphincter relaxation happens, but good rectal pressure increase. What do we recommend next or conclude?
So as I told you, the balloon expulsion is normal. There is no dyssynergy. So the London has already labeled that differently. Yes.
During RAIR, what software gives results in the form of more than 20 or less than 20 Hg reduction in total
No,
anal?
so no software gives you that actual value, but you know what is the pressure at baseline in the sphincter, and you know what is the pressure when the sphincter has relaxed. So if it is 100 at baseline and now it is less than 80, that's a 20% reduction. So that you will have to do it manually sometimes, but very often it is quite evident. You don't have to do that. It's just visual uh, interpretation, and very times it's very evident that there is a clear relaxation of the anal sphincter.
Can you tell how to differentiate between IAS and EAS pressures in topography once again?
Okay, so at rest, whatever you're seeing is predominantly the internal sphincter. Okay, and when you ask the patient to squeeze, okay, what you are seeing is the incremental increase because of the action of the external sphincter, right? So if at rest, the internal sphincter pressure was 50, and now the patient has squeezed, and now it has become 150. So the rise of 100 is because of the external sphincter coming into play. At rest, 70%, 60-70% is the internal sphincter's action. So for practical purposes, at rest, whatever you're seeing is the action of the internal sphincter. At squeeze, whatever you're seeing is the action of the external sphincter.
According to London classification, what is the success rate of biofeedback therapy for different entities? Is it recommended in all types, abnormalities such as BET, propulsive, or dyssynergia?
So this is a question which actually needs, I think, more studies, because there have been many published literature which tells us that the biofeedback helps in 70%. So that is the average value which, especially Dr. Satish Rao's paper quote 70% of success in biofeedback. But in my personal experience, also my usual experience, to be very genuine and frank, is around 50%. 50%. So
Okay.
I see a good response in especially the younger people who have dyssynergia. Because you see, for biofeedback, um, it is very important that the patient should be cooperative, he should be engaged in these sessions. And that is done very well with younger people. They are willing to change, in my personal experience. So they do really well. The younger people accept that there is a problem and they're willing to change that, and they do it efficiently. And usually around fourth or fifth session, you will see a very good change in such patients. But if you ask me the numbers, I think it should be between 50 and 70%.
Next, balloon expulsion. What can be used for inflation? Water or air? And what's the volume advice? It's 50 ml. Sometimes patients may have megacolon, sir. In this situation, megarectum, how do we know how much volume to give and things?
Yeah, so there are two places where the balloon inflation helps you. One is for seeing the rectal sensations. So for a rectal sensation, we usually inflate it with air, because doing it with water with 10 ml increments becomes very, very difficult, right? So we do that with air for a rectal sensation. So 10 ml air, then 20 ml air, then 30 ml air. I mean, we do it on a contiguous fashion. But when you're talking about balloon expulsion, we will be using water, because I think with the air-filled balloon, it might not be very physiological for asking the patient to evacuate that. So that is why we ask the patient to do that with a water-inflated balloon. So that is our practice, but it's not a standard. You can do it either with air or water.
With regard to volume, sir, 50 ml, and sometimes do we have to increase it for some indications?
Yes, yes, yes. So you can inflate it maximum to 300 ml also. For patients with megarectum, you'll need more rectal inflations to elicit those sensations. Especially patients with megarectum will not complain of any sensation for 100, 120, 200 ml also. So up to 300 ml, it is okay. There have been reports when there is a rectal perforation because of a large volume rectal balloon inflation. So usually we do it only up to 300 ml, and
Uh,
we have never faced this situation anytime.
Sir, any symptomatic treatment for proctalgia fugax?
Symptomatic treatment, I think, lies on these neuromodulators, the tricyclics and SSRIs. But I think biofeedback is one thing which has been not used very commonly, but there have been many reports that it works. And basically, if you're able to identify any such patient, I think you should try with the biofeed. It might just be very useful.
Okay. Do we need to suspect anorectal dyssynergia and chronic constipation with no urge and no history of digital evacuation?
So these symptoms in patients with chronic constipation are not seen to be very, very, reflective. Okay, though that patients who have a history of manual evacuation or incomplete evacuation tend to have more dyssynergia, but it is not a one-to-one thing that anybody who has dyssynergia will always have a history of manual evacuation or incomplete evacuation or vice versa. Test probability increases, you should do it in all such patients, but it is not that the symptoms have a very clear, defined distinction based on subtyping of classification, subtyping of constipation.
How does biofeedback help fecal incontinence? Can you explain a little, sir?
So for fecal incontinence, your purpose of doing, what is the aim of treatment is to increase the sphincter pressures, right? So how do you objectively assess whether the sphincter pressures have increased? There is no other objective way to find out whether the sphincter pressures are increasing except putting up that patient on a manometry system. Okay, because you will ask the patient to do Kegels exercises and he'll say, now I think my pressures are normal or they have increased. How do you know that? How do you know that? So you just hook him up to a manometry system. You know the baseline pressures. He's undergone sessions of Kegels exercise or some physiotherapy, and now he's come for follow-up, and you just find out whether he's done well or not. Similarly, if you're doing biofeedback on that system and Kegel and the squeezing exercises on the same system, you know that with every session, there is some improvement that is happening. His average pressures are increasing with time. So it gives you an objective assessment.
Okay. Sir, in London protocol, is balloon inflation needed to do a push maneuver?
Yes. Yes. 50 cc.
Okay. This question was already asked about sigmoidoscopy prior to the procedure. I think it's a common practice to just see if there's any mechanical before doing it.
So that is what we are so tuned to doing a colonoscopy, sigmoidoscopy that we tend to do that, but it is not mandated.
Okay. Does management strategy changes a lot based on the type of dyssynergia?
So that's a good question. So basically, see, when we talk of dyssynergia, the problem is one at the sphincter or two at the rectal pressure generation, right? The sphincter, the problem is it is not relaxing completely. So sphincter relaxation is one of the targets that you need to focus. The second target is the rectal pressure generation. So for if the rectal pressure is a problem, then you target increasing the rectal pressure. So how do you increase the rectal pressures? By increasing the abdominal pressures. How to increase the abdominal pressures? By abdominal exercises. So you train the patients for abdominal breathing or abdominal exercises, which help in assisting in increasing the abdominal pressures with ease. Okay, so based on the types of dyssynergia, you would be targeting either on the sphincter relaxation or increasing the abdominal pressures or both.
Okay, cool. Sir, in case of loop colostomy, sigmoid, or transverse, does the parameters of ARM change due to stoma?
No, no, no. So ARM is only focusing on your anorectal apparatus.
Not
So
the
the
stoma.
parameters remain the same irrespective of where the stoma is.
What balloon is to be used ideally?
So the manufacturer gives us, I think it's a latex balloon that the manufacturer gives. I'm not very sure it's a latex or a silicone balloon, but again, this thing is not something which is very standardized. You can talk to your manufacturer for providing a balloon and they usually give it with your anorectal system.
If the catheter comes out while pushing, then what do we do? How do we proceed, sir?
Again, push the catheter in and do it back. So again, so as I told you, the catheter comes out if the patient is asking, you have asked the patient to evacuate, right? So that itself means the evacuation is normal if you're talking about that. I am not very certain why many people are asking this question. This usually does not happen so frequently. Maybe that you've not pushed the catheter in sufficiently that it is coming out so easily outside. You have to push the catheter around 10 centimeters inside to make sure that it stays in most of the patients.
So most of us use lignocaine. So which jelly did you tell and
KY
what is the
jelly,
difference?
KY jelly. There is something called KY jelly. The gynecologists use it very commonly.
Okay,
It's a lubricating jelly without any anesthetic action.
great. What alternatives can we use if we don't have balloon?
Somebody just put up a question. Many centers use normal party balloons, so I don't think that is recommended. So at least for medical purposes, I think there has to be some semblance that you use at least medical grade products. And I would not recommending using a party balloon if unless you are actually pushed to the wall. So as I told, there is no standardization of such a case. But I think the party balloons are too thin and they might, rupture very easily. Just destroying your procedure. So better to use a medical grade balloon.
Cool, sir. Actually, next end of this month, after fourth week, we have a session on biofeedback session by Dr. Rajesh Ainani, sir. So there probably we'll have more discussions on biofeedback, its frequency. So few of the questions are here on biofeedback therapy also. That's for the audience here. So one of the question is, in this era of AI and newer manometry machines with highly developed software, how the role of gastroenterologist has changed in interpretation of manometry results in upper and lower HRM?
So I think AI, if you ask about AI, so there are two, three things I like to bring into this. So first of all, let me talk about the anorectal manometry. So one thing where manometry might change in the future is 3D manometry. So what you're seeing now is 2D manometry, two-dimensional. So these you are seeing colors and graphs and all. So as doctors, because you know the physiology and you know what is being seen, it is easy for you to understand. But for patients, sometimes it becomes very difficult to tell them what is actually being seen, especially if you're doing a biofeedback session. Okay, so if you actually get a 3D manometry, which is likely to come up in the future, they might understand it better. They might understand what is actually being seen. They might see the sphincter squeezing when the rectal evacuation is trying to occur. So that might be a useful add-on in the future if you talk about anorectal manometry. For esophageal manometry, again, so AI, so it is not actually AI, but you see, most of us are depending on what the manometry machine is diagnosing, especially for esophageal motility disorders. And you take that at face value, okay, which should never be done. There is a 50% fallacy with that. 50% of the times, whatever the manometry machine is diagnosing is wrong. You have to do a manual study. Okay, so make it be very, very sure that whatever diagnosis, you will just click on that button that use Chicago protocol and the diagnosis just comes up like that and you just print that report, but that is wrong 1 and 2 times. So don't use AI. So this is not actually AI, but this is a form of AI that everybody is using. That should not be done. But I see a lot of utility of AI in esophageal manometry in the future, because the next iterations of Chicago are likely to focus on two important things. One would be an inclusion of the impedance system in manometry. So impedance is basically tells us you about the bolus transit. Okay, so you will be having more complex algorithms correlating between the transit of the bolus and the esophageal contractility. So right now you're only seeing about the esophageal contractility. You're not correlating it to the bolus transit. You see, what actually matters is how well the bolus goes down, right? So that might be a thing of the future where AI will come into play. And also for the upper sphincter, the upper esophageal sphincter is a very complex apparatus. It is made up of skeletal muscle, and there the pressure changes are very rapid. And we still don't have metrics to diagnose that as of now. So in the future, I think that is one place where the AI might come into play in esophageal manometry.
Okay. How to make rectal sensory test more objective? Because many times patients' response keeps varying.
No, I agree. So that is a very good question, but that is why I think there are three sensations which have been recommended. Okay, so the first sensation, the second sensation, and the third sensation. There might be some fallacy in the first sensation, but then the other two sensations might come. But in my personal opinion, so there is a slight variation. But you see, you are looking at a range. Okay, you are not looking at absolute accurate values. So again, as I told you, these are physiological tests. So don't go by these individual numbers. You'll have to use your uh, general, wisdom to interpret these tests in the clinical context, irrespective of what is coming up in the reports. Okay. So if the patient is telling you of certain sensations and you feel that the patient is not cooperative, or if the patient is very elderly and is just not understood what you're telling him, so there you need to, you have to be very clear that probably I'm not recording it in the correct way. So these all things have to be looked into. Language barrier is there many times, especially for elderly patients. It is very difficult to explain that you have to tell me these sensations, right? So that is your own interpretation. So that is where your general wisdom comes into play. And you will have to see for three sensations, that is where your chance of error slightly goes down, and you would usually look for a range. You would not look for an absolute value.
Sir, what amount of air is used in children to do RAIR?
So that depends on the age. For very small infants, 1 year, 2 years, we start with 10 ml. 10 ml is sufficient to elicit an RAIR.
Okay. Sir,
And gradually you can go on increasing that.
Okay. Sir, how to advise self-biofeedback methods?
So, self-biofeedback, there is a paper published by Dr. Satish Rao where they had used a device which it was there. You had a capability of inserting it by yourself and seeing the graph on a handheld monitor. But that instrument is not available in India. And I even tried to reach out those manufacturers. They actually were from Hyderabad. But they had done that only for that purpose of that study, and they subsequently have not uh, produced that in commercial numbers. So as of now, you don't have a self biofeedback device, as far as I know. I'm not sure whether it is done in the West. It might be because Dr. Satish Rao keeps publishing on that. But in India, as of now, we don't have a self biofeedback device.
Okay. Great, sir. So question keeping on pouring, but then we'll have more sessions to come and we'll definitely involve you again and again for different, more specific topics, sir. Very, very informative session for all of us. Many of them who are messaging congratulatory messages for such sessions. So it's a pleasure and privilege to have you here. Thank you, sir. And I also thank Reddy Stock, Mr. Narayan, to push us to actually be so enthusiastic in organizing such wonderful sessions. Really thank you, sir. Thank you.
Thank you. Thank you, Dr. Prashant, and thank you everybody for being online. Thank you so much.
Thank you, sir. Thank you.